with, we go to the high magnification. It's a solid growth pattern, and when you look at the individual cells, it is in the same category that we were discussing before, this cohesive cells, and what's our differential diagnosis here? Well, we will look at it. So, clearly our differential diagnosis here is a solid DCIS versus a solid LCIS, right? And it's based on this cohesive growth pattern and uniformity of the cells. I definitely would favor a lobular lesion, but on these solid lesions, in-situ lesions, I always utilize Ekaterin. So for us, the Ekaterin expression versus lack of expression defines the lobular differentiation on these lesions. And this was Ekaterin negative in-situ proliferation. So based on that, we made the diagnosis of lobular carcinoma in situ. If we go around a little, there are definite areas. The nuclear morphology is a little more typical. So based on that, we recommended that this is a pleomorphic lobular carcinoma in situ. When you make the diagnosis of pleomorphic lobular carcinoma in situ in a core needle biopsy, one very important thing is that we rarely see pleomorphic lobular carcinoma in situ as an individual lesion. So always look around for invasion. That is what I always tell my trainees, that if you make a classical lobular carcinoma in situ on a core needle biopsy, if that lesion is going to be excised or not to excise, depends on multiple additional factors, mainly the clinical presentation and her family history and all those things. So when we make the diagnosis of lobular carcinoma in situ, classical type on a core needle biopsy, these patients go to our multidisciplinary planning clinic, and then we make a decision if it is going to be excised or not. And the main feature in those patients that we evaluate is the imaging presentation. If this is an incidental finding, if it is a mass-forming lesion. So if it is a mass-forming lesion, no matter how small the mass is, if the imager is saying that there is a mass, in that we always have these patients go to excision, and then we do the surgical excision. And if the patient has a high risk because of the family history or other reasons, she could be consulted for bilateral mastectomy, or as Dr. Arun was mentioning yesterday, for the chemoprevention trials. But if we say it's a pleomorphic lobular carcinoma in situ on a core needle biopsy, that is an indication to do the excision of the lesion. Because we rarely, I must underline rarely, see a pleomorphic lobular carcinoma as an isolated lesion. There are frequently invasive carcinoma somewhere adjacent to pleomorphic lobular carcinoma. So when I make a diagnosis of pleomorphic lobular carcinoma for biopsy, I always look at the deeper levels, and if I don't see it, when I go home, I always think about that case. That is always in my dream. Did I miss that? Couple cells, invasive lobular carcinoma. So when you make the diagnosis of pleomorphic lobular carcinoma in situ, always look very carefully for small foci of invasion. So that's the take-home message. There is on this one, there is invasion, yes. You mean multifocal inside, multifocal based on mammographic findings, or on the slide you say over here, over there, over here? Okay. Frozen? We usually don't do frozen for flower lesions. Okay, are we talking about the classic lobular carcinoma site or pleomorphic lobular carcinoma? Well, the thing is that in general, lobular carcinoma site is considered to be involving diffuse fluid, so it's, by definition, it's in most cases a multifocal lesion. Treatment of this case or the case that you described? Well, that's the thing. Those patients have different therapy approaches. One approach is to wait and watch the patient, like in some centers. These patients are followed by MRI. And at the same time, they are eligible to get a mastectomy, even to get bilateral mastectomy. So we have a special clinic for these patients. So based on their family history and other factors, they are consulted, and then, like if she is based on her age, is she willing to have a bilateral mastectomy or want to go to chemoprevention trials. So there are multiple options, and these options are not only based on what we see morphologically, but how clinically they are going to be managed. Because some patients have so dense breast, so even MRI is not a very sensitive to pick up their lesions. So imagers say that this is going to be a very difficult lesion to follow. And other patients, their breast is a lot easier to follow by imaging. So case by case, they are making decisions on this.
Regarding the state of the surgery, conservative versus radical is
So for lobular carcinoma in situ, taking the lesion itself is not really curative. So because with lobular carcinoma in situ, we are thinking that this is in some instances, it might be the precursor lesion, but we are thinking that this is a risk marker for generalized risk for the entire breast, including the opposite breast. So its strategy needs to be made for prevention of development of invasive carcinoma. The reason we are excising the lesions when we have either pleomorphic lobular carcinoma or core biopsy proven classical lobular carcinoma in situ to exclude areas of invasion. So we are not doing it to treat lobular carcinoma in situ. Our goal for recommending excision on these cases after corneal biopsy is to exclude presence of invasive carcinoma.
So lobular, after removal of the lesion, lobular carcinoma in situ pure and invasive lobular. What is the surgery?
Okay, if it is an invasive lobular carcinoma, then the surgery is going to be directed towards invasive carcinoma. So it can be based on patient's choice and other things. It could be segmental resection. So invasive lobular carcinoma or presence of in situ lobular carcinoma does not mean that the patient needs to have a total mastectomy. So invasive carcinoma is going to be treated just like any other types of invasive carcinoma. And if you get a negative margins, that's the treatment. But presence of lobular carcinoma in situ, in addition to invasive carcinoma, puts the patient into a high risk for development of invasive tumor in the rest of the breast parenchyma. So based on that risk, she can be put on chemoprevention. So it is two different things. So like, I don't know if you were here for the case presentation yesterday, even in BRCA1 positive patients, when we have an invasive carcinoma already developed, the treatment is for the invasive tumor, and that can be segmental mastectomy very easily. So presence of lobular carcinoma in situ or BRCA positivity doesn't change the treatment modality of the invasive tumor. But what it changes is that the risk of developing additional tumors on the opposite breast is different. So the chemoprevention strategies need to be discussed for development of additional tumors, not the invasive carcinoma. Is that clear? Okay. Any questions on that? Any comments? Any comments, Dr. Manal?
So why you hate fine needle in breast?
What?
Why you hate fine needle aspiration cytology in breast lesions? Why you don't follow or put the fine needle aspiration cytology in evaluation of breast lesions?
Why we don't put it?
Yes, as a
Oh. Okay, you do it?
yes.
Okay, why do you do it?
No, I'm asking you. Tell me first.
Okay, you tell me why. What are your indications? Tell me about that.
Okay, let me tell you. Okay, you know what happened in finding aspiration cytology in areas like Egypt or the communities where the socio-economic or limited resources, it can be very beneficial because many patients will receive very advanced disease and present with axillary lymph node deposits. And then in such cases, we can just at least to triage the patients to have second or tertiary referral function, or even in certain circumstances, we can do fine needle in the breast region and also the axillary lymph node to evaluate given the stage of the patient. This is number one. Number two, also in many circumstances, patients present with defined apparently benign lesions that the patient may need some sort of assurance and even final diagnosis based on the fine needle, like in fibroadenoma or fibrocystic or ductectasia or something like that. So it can be very beneficial in such cases, especially as I told you, we have a limited resource regarding core needle and H&E or histopathology service in collaborative country. So this is some of the beneficial issues. Also in surgical failure for patients where they cannot be good for surgery, also we can apply FMA service for those patients to give it to get the patient good diagnostic decision. So this is why we do fine cytology in our unit. I know core needle biopsies can be advantageous or maybe superior to fine needle because of new staining, because of invasive versus non-invasive, as you claim. But we should admit that part of the practice of abroad also the concern with the medical-legal consequences and trained psychopathologists. So we should admit this also, that not every ordinary pathologist or even general pathologist can do psychology service in a program.
I completely agree. And in any of these ethics, coordinate biopsy versus FNA, or you really need to tailor to your community, and you really need to tailor the patient population that you are serving. No question about the utility and advantageous aspects of final aspiration that you have mentioned. In the United States, starting maybe in last decade, the number of FNA procedures that we utilize for the evaluation of breast lesion have significantly decreased. The main reason for that decrease is the all the developments and technical advances in core needle biopsy techniques and all these core needles that now we are getting, the size, the amount of tissue that you receive. So that really reduced the need for evaluation of the primary lesions. In early 80s and 90s, we did a lot of final aspirations of breast lesions. And right now, with the same similar procedure for similar price, we are getting these large biopsies. And now, yes, you can make a diagnosis of carcinoma in final aspiration in the evaluation of primary lesion. There's no question about it. But in addition to establishing the diagnosis, now we are utilizing additional tests to obtain additional information. Right now we are doing PRPR2, but maybe we will also utilize some of these samples for next-gen sequencing pretty soon for additional things. So core needle biopsy, without a question, gives you a lot more tissue for similar procedure for similar price. So you really need to make a balance between amount of tissue that you are getting and amount of information that you are going to obtain from that specimen. If your question is this lesion benign or malignant, and am I going to refer this patient to the tertiary care center, or we are going to handle it locally? Yes, for that purpose, FNA has a superiority, and you can do that. In our practice, we always do the core needle biopsy of the breast, but for additional lesions, including axillary lymph node sampling, or the patient has a supraclavicular lymph node, or the patient has an additional lesion in the same breast, a satellite lesion, we can utilize fine needle aspiration, and we are utilizing fine needle aspiration for that. For all patients with palpable, clinically positive lymph nodes, our main technique is fine needle aspiration. So all these techniques, you really have to evaluate how you are going to apply in your setting and how you are going to do it. So I'm not against FNA. I am not a trained cytopathologist, so I cannot do it myself, but we have a very active cytopathology department in our institution. And we have multiple clinical protocols where we establish the diagnosis with core needle biopsy, but obtaining additional material for some molecular studies, we still use fine needle aspiration.
So I do cytopathology and breast, so we still get some it's not a big one, but we do get some FNA from the breast in cases where there is, it's a young patient, the clinician is suspecting it's an abscess, for example, or a benign cyst, even a fibroadenoma. We get aspirations from fibroadenoma when they're thinking it's probably benign.
Exactly the same situation for me, and I think that I was trained to cytopathology in a cytopathology school in Canada. I did the training of cytotechnicians when I was a resident in pathology, so I loved cytology. And my concern is that today people now don't know cytology, and our residents are no longer trained for cytology in breast. But the problem is that we don't need it anymore. Now we do biopsy for everything, and I have exactly the same experience as you have. It's only for abscess, cysts, and sometimes for fibroadenoma, but most of the time they do biopsy of fibroadenoma. So, and for all the rest, we have biopsy. But now we are losing that, but because nobody is knowing that in France anymore. We are losing the
You are from France and America. Okay. Dr. Vale? Vale? No, Vale. This is a very famous pathologist. But no. Look, he is doing FNA. And Shahla Masoud in the States using FNA in this. Right?
I want to just add a comment for this region for which you do fine needle. I have trained on fine needle aspiration cytology with 3 years in South Korea.
Yes.
And
in Sweden, Stockholm Institute.
No, fine needle, in addition, there is a very important lesion which maybe the Western not minded with because it's rare in these areas, but it's very common in our country and in other Islamic countries, especially in Turkey, is granulomatous mastitis. The problem of granulomatous mastitis is that clinically can be misdiagnosed as malignant. Radiologically, it may take by rank 4 and 5, and even at operation.
Yes.
And in this lesion specifically, fine needle aspiration cytology is very beneficial. It's very beneficial because you see classic appearance. You see chronic and acute inflammatory cells, and you see multinucleated giant cells, and you see a lot of foaming macrophages. So it is not fibrosis, it is not abscess, because you see a lot of chronic inflammatory cells. It is characteristic cytologic features. And I published last month an article in Active Cytologica about this. We have collected 69 cases, and this is a very big in the States and other European countries, maybe 5 or 10 cases in 10 years. So it may be this one of the lesions in which the fine needle is very helpful.
Dr. Salam, in addition, immunohistochemical studies can be done on fine needle aspiration easy.
I had a case I showed you in the conference last month of breast with Adel Raha. I stayed fine needle aspiration cytology, not the cell block, the smear. I stayed with ER, KI, and HER2. They are so nice. They are so nice.
Because not only, even fish can be severe in cytology material over the tissue because the truncated nuclei is not existed anymore in the cytology material.
In the fine needle is not severe. You have to.
I want to ask you about fine needle aspiration in the United States. If you need to do fine needle aspiration for a certain lesion, can you do it perfectly and
Sure. Certain markers, for example, ERPR works perfectly, but HER2 immuno it cannot be done, but we utilize FNA for fish. It works beautiful.
Especially follow-up of the patient in the currents and metastatic disease
Yes.
in the era of tumor heterogeneity.
Yes.
And this is the era nowadays.
Correct. Okay, let's go to another area of controversy. Okay, I'm sorry, I missed the sentinel lymph node talk this morning. I wasn't here, but so we had a talk on sentinel lymph node, so you all know how to evaluate it. So I will show you a sentinel lymph node. This is a patient with invasive ductal carcinoma, had a segmental resection, and this is the sentinel lymph node. And I need you to look at it in the low magnification and evaluate the section, just 1 minute. So there is this focus of carcinoma, as you can see very nicely, and then there is another focus right here. So the larger focus here measures 1.5 millimeters, and the other focus measures 0.04 millimeters. So in putting it together, these two separate foci, it definitely is less than 2 millimeters. So what is the lymph node staging on this? Okay, who listened to the talk this morning? Come on, guys. Okay, what's the end stage? in brackets micro. Do you agree with that? Okay, as an expert in the lecture, do you agree with that?
It seems to be between 0.2 and 2 millimeters.
Yes.
The PM1 NI.
Okay. So if that focus, putting that focus together, if it were together more than 2 millimeters, what would you do? Well, I'm asking the expert. She gave the lecture.
More than 2 millimeters is micrometers.
Okay.
No, okay, no, we don't have. Bigger one, okay, I'm sorry. No, we don't add. It could be a problem, I think.
Okay, so the question is, if this single focus were more than 2 millimeters, then it would have been a macrometastasis. But we do not add 2 separate foci. So this is what the recommendation is. In my heart, I really don't believe in it personally. Because really, but biologically to me, what it makes sense is how much tumor you have there. So why did we come up with that 2 millimeter and you don't add that 2 foci? What's the biology behind it?
I'm sorry, I didn't. I was looking to my screen, so please ask me the question again.
Okay, so in terms of lymph node staging, we do not add 2 separate foci of metastases. We go with the largest metastasis, largest focus. And what is the reason for that? What is the data that we have not to do that? To me, the most important thing should be the volume of the tumor, why we don't add it together.
So I don't have a clear answer for that, but what I can say and what I showed this morning is that in some cases it's very tricky because we have, for instance, very small foci all around the node, and not seeing that as a mass would be a mistake. And sometimes when you have 2 foci in a lymph node, if you do some cuts, you will find that it's a big one. So that's why I still like doing levels in the nodes. I don't do immunohistochemistry anymore, but I still do levels because sometimes when you have 2 foci, it's good to go deeper in your node, and sometimes you think that it's a bigger metastasis.
So I definitely agree, and the thing is that when we have these defined criteria, and when we are applying in our daily practice, we really need to use our medical judgment. So if I have something like this, and then if this is really coming close to, is it really 2 millimeter or it's not, it's like 1.9, I don't really believe that the biology should be dependent on as if we are making such a precise determination. So I always, if it is going to make a change, I always do deeper levels and to see if it is going to make a difference. And the other important thing is that most of the time when we evaluate our sentinel lymph nodes, we do serial sections, and then the big lymph node, those serial sections will end up in multiple cassettes. So if you have a small focus of metastatic tumor like this, and it is present in more than one section, then I try to calculate that amount, not only the measurement on the slide, but also because most of the time your section is not really less than 2-3 millimeters. But if it is present in 2 consecutive slides, then I will try everything to bump the lesion to macrometastasis. So yes, these are